For our final guest of the morning, please welcome Health Transformation Strategies Managing Partner, Dr. Liz Fowler. Thank you so much for joining us, Liz. It's great to have you here.
Thanks for having me.
Bright and early. So you, for those of you who don't know, Dr. Fowler served as the head of Medicare and Medicaid Innovation during the Biden administration. And we just heard a little bit about innovation in value-based care and the need for new technologies. There's been lots of buzz in the last 2 weeks about this new CMMI access model, which would test the feasibility of Medicare paying for digital health tools to improve chronic care. I'm curious what you think about that. Is that the direction that you would have taken things?
I am really interested in the model. So first of all, just want to give kudos to the CMMI team for continuing the pace of really interesting, innovative models. I think it's a really interesting approach. I think there's a lot of details still to be worked out, so looking forward to reading the request for applications, but I think it's bringing those new technologies into Medicare in a really innovative, thoughtful way, and specifically to beneficiaries in traditional Medicare who might not have had access previously. So details still to be rolled out, but really excited to see it.
What are some of those big outstanding questions that you still have?
Well, I mean, I guess not to get into too many details, but just how they're going to measure quality, what the outcome measures are going to be. In the technical Q&A, there was talk about randomizing patients. Be interested to see how that will work and who's responsible for that. And then also just the sorts of technologies and innovations and new strategies that will be accepted into the program, like specifically what are they looking for, and about how the payments will work. I mean, so many questions, but
lots of details.
Yeah,
the devil's always in those, right? In these models. Do you have any communication with Dr. Oz and Abe Sutton, who took over your role?
I have conversations with my colleagues who are in roles now and really appreciate that partnership and ability to still have those connections and communications. I think the nice thing about the Innovation Center is that there's a lot of bipartisan interest in trying to figure out how to deliver better care at a lower cost. And so to that end, I think there's a nice camaraderie across administrations when it comes to the Innovation Center.
Yeah, absolutely. They've certainly been busy, and there's another model that they put out earlier this year called the Wiser model, which would introduce some AI-powered prior authorization into traditional Medicare. And I know you've done some writing on this. What do you think about that? There are some people, some Democrat elected officials who are very skeptical of this model.
Well, as I said in the Health Affairs article, I think they're raising some good questions and legitimate questions, but I also think it's worth testing. That is the point of the Innovation Center, is testing things, and if they work, looking for ways of expanding them. If they don't work, pulling it down and looking for a new direction. I think what's really exciting is that we tried to figure out a way at how do you get at low-value care. The other speakers talked about the perverse incentives in fee-for-service medicine that results in a lot of low-value care, a lot of waste, a lot of abuse, and I think this model is a way of getting at some of those. And so I think it ought to be tested. I think we ought to be looking closely to see how it's going and make sure that it's not creating new administrative burdens for providers, that it's not standing in the way of appropriate, necessary care for patients. But I think it ought to be tested, and I applaud them for doing so.
Yeah, it's a big swing. It'll be interesting to see how that plays out, as with all of these things. On the flip side of traditional Medicare, more than half of seniors now choose Medicare Advantage. And there are obviously a lot of reasons for that, but many analyses say that it's costing the federal government too much money compared to traditional Medicare. What changes would you make to Medicare Advantage?
So that's a good question, and I think there's now a request for information seeking a lot of input. So those of you out there who have been critical of the program, now is your moment of weighing in and sharing those views. I think there's changes that could be made to the star ratings program. I think the recent proposed rule gets at some of those shortcomings. I think there's more that the administration and potentially with Congress could do to update and modernize and continue to look at risk adjustment and ways of making sure that it's really reflecting patient cost and not just the ability to code. I think that's an important change. I think just looking at the payment system now, if I was in my prior roles thinking about sitting in a policymaker seat, why are we still tying payments to fee-for-service Medicare? If 50% and more are in Medicare Advantage, why are the benchmarks, the payments, still tied to a fee-for-service program? It's almost like the tail wagging the dog. So I think we need to do sort of a more whole-scale look at the program, but it requires Congress too, not just the administration.
Is that something that you think CMMI has the authority to test out by itself?
Well, if you look closely at the RFI, it did come from CMMI. I think they're looking at ideas. I think we were looking at ideas, and I think this administration is continuing that sort of investigative approach to looking at how to make the program more competitive, more efficient, more reflective of what patients want. And so I do think there is the authority. Now, the problem is we had a voluntary model in CMMI when I was there. It was actually a model that was started by the first Trump administration, and it ended up costing more. It didn't save any money. It actually led to higher spending in Medicare Advantage. So it does beg the question of can you actually have a voluntary model in a program like Medicare Advantage that saves money? And I think the answer might be no. So that sort of does suggest that they need to take another approach and think differently about what a model would look like.
Yeah. I mean, voluntary versus involuntary participation, mandatory participation in these models is a question that has long been debated. And we're seeing some mandatory models out of this administration. You also did some mandatory models. What do you think is the future there? Is that the way that we need to go?
Absolutely. I think we absolutely have to look down the road of mandatory models. I mean, otherwise you're still reflecting the providers who want to make change, who want to move in a different direction, and that's great, but you're not catching those who are doing just fine under fee-for-service and in fact are still taking advantage of all of those incentives, those perverse incentives that the other speakers spoke about. So I think if you really want to change the system, I think you need to look down that road. And CMMI was always criticized for not saving money. It's almost impossible to save money in a voluntary program where you can sort of decide if you want to jump in. If you're not winning, you jump out. So I think it addresses a lot of those concerns too.
Yeah, and I think that's an important, bigger point, right? It's been more than a decade of experimentation in CMMI. A lot of value-based care models still struggle to produce savings. It's hard to draw in providers that aren't already willing to do this work. What is the big structural issue here that we haven't solved yet?
So first of all, and I have a bee in my bonnet about this, the whole process for what counts as savings.
Yeah.
CMMI is held to a much higher standard when it comes to what is savings. It's on a net basis. And so there was conversations about paying for primary care differently. If you give incentives to primary care and sort of prospective payments and investments for them to invest in the technology and the infrastructure they need to make value-based care work, that counts against your net savings. The ACOs, which I think are the future of traditional Medicare, in the traditional ACO program, Medicare Shared Savings Program, every year there's an announcement of shared savings, how much goes back to the ACO organizations and how much did Medicare save, and we all applaud that. In CMMI, all the money that goes back in shared savings to ACOs counts against the net savings. And so it's almost like you're digging out of a hole that you can never quite dig out of. And so I think the way that the statute has characterized savings and set the bar for what we expect for value-based care is probably too high. I saw a lot of models that worked and a lot of good innovation, but it can never get over that sort of hurdle in the way that we define success in the statute.
That's very interesting. And so would it take Congress to change that interpretation?
Probably, or just a different mindset.
Yeah.
I think there's also this sort of, everyone has these high expectations that CMMI is going to save our healthcare system, and if it doesn't work, then we're going to pull it down because it's not working. I mean, it's a very small investment in innovation to test things that may or may not work. That is the point of innovation, is to see what might work. But you can't rest everything on the shoulders of that organization in a voluntary model with those very high bar standards and expect that it's going to save our healthcare system. It needs to be a larger conversation, but it is certainly part of the solution.
Yeah, it's interesting. I'm also very deep in the weeds on a lot of these topics, and I understand how hard it is to make change. And then I go out and talk to patients, and they're desperate for change, and providers too. And so, how do you strike that right balance of making sure that things actually work and benefit the federal taxpayer while also bringing change to the system that badly needs it?
I mean, I think the debates this year over H.R. 1, over the enhanced subsidies, suggests that there needs to be a larger national conversation about where healthcare is going. Everyone wants to point a finger and say, it's your fault, why our system isn't working, but the system is what it is, and we need to take a system-level approach. It's not that the marketplaces are somehow an anomaly and costs are increasing astronomically. Look across the system, that's happening across the system. So we need to step back and really have a larger conversation about what we want our system to look like, because it's not working for patients at all. And I think, we used to have the mantra, well, the US has the best healthcare system, and when I started in healthcare many, many years ago, US has the best healthcare system in the world. I don't think anyone would say that now. I think it used to be you could say that, well, if you were wealthy and could figure out how to get what you needed. Now I think even if you have money and you have good insurance, it's really hard to figure out how to get what you need and how to get care for your family, let alone if you're still struggling to figure out how to pay premiums and enroll and get access to providers. So I think we really need to have more of a national conversation, and it needs to be both sides of the aisle. I heard a lot of similarities and a lot of common themes from the previous speakers, and I think there's a solution there if we all want to reach up and grab it.
Yeah, a refrain that I've been hearing more lately is insurance is not synonymous with access.
Exactly.
Yeah.
Exactly. Can I just make one more
please.
point, which is I think we need to get away from the language of who deserves health care and who doesn't. And I think that was a sort of a fundamental principle in the debate over the Medicaid reforms. Who's deserving of health care? If you really want to make America healthy again, we all need to recognize we all need access to health care. We all need to be able to see providers. We all need to be able to take our kids to the doctor when we're sick. It's not a matter of who deserves it and who doesn't. And I think getting away from that language and really thinking about healthcare differently is part of the solution.
And good segue into the news of the day, which obviously we have to touch on. Big vote coming tomorrow this week on whether to extend enhanced ACA subsidies. And you helped create the Affordable Care Act as a staffer in Congress. What do you want to see happen here, and what do you think the future of the ACA needs to look like?
I mean, I think we need to step away from the dialogue of, as I mentioned, like it's not working, we need to tear it down, we need to rethink it, we need to, rely on mechanisms to give more money directly to people. I think that's not the solution that's needed here. Again, millions of people have relied on these marketplace plans. It's been a really important lifeline for a lot of patients, and I think taking that away from people and making it less affordable, I think is just not a place you would want to be, I think, politically or sort of ethically and morally, in my view. I wish that we could be having a different conversation, but it feels like that moment passed this summer when we passed a bill that really looked at moving in a different direction and also didn't fix this problem.
Mm-hmm. Yeah, well, we'll all be watching. I'm sure everybody in the audience will be as well, as we see what happens the rest of the week. Thank you so much, Liz. It's great to talk to you.